This is the meeting of the CB14 Health and Human Services Committee, and we are both fortunate and I think honored to have some really terrific people speaking to us today about health matters, COVID updates, the situation with people in need of stable and permanent housing. And I think I saw Afia Frimpong. I saw her name pop up. And Afia, I would just like to say hello and welcome. And
thank you.
And I'll let you tell us more about you, but I'm actually familiar with some of your work through the Brooklyn Perinatal Network. I'm a midwife, and
nice.
I have heard you. I don't know if you ever came to Brookdale, or some of your team did anyway. Point in the past, and so I'm going to shut my mouth and let you take it away.
Oh, that's amazing. Nice to meet you, Nina. Yes. My name is Afia Frimpong. I am the North Brooklyn Community Liaison for the Department of Health and Mental Hygiene, Office of External Affairs. My background is public health, and as Nina mentioned, I do have a passion for maternal health. I am a full spectrum doula as well as a lactation counselor. And I do some contracting and consulting for Brooklyn Perinatal Network, as she mentioned. But today I will be giving updates on the COVID-19 status here in New York City. And hopefully I'll be able to answer any questions that anyone has. If I'm unable to answer anything, still shoot me your question and I'll be sure to answer it by tomorrow for you. So Nina, whenever I can start giving the updates, please let me know. Everyone, I apologize. For some reason, I'm having camera issues, so that's why, and audio issues, so that's why I called in, so at least I'm able to still communicate with you all. And I just want to know, am I still going to be able to share my screen? Because I wanted to show you guys how to access the data, the most recent data on the health department's website, more specifically pertaining to your community board.
Hi, Afia, this is Anya. I just made your, I hope I made the right account, the presenter. You should be able to share the screen. It's the one that says your name, Afia Frimpong, right? That would be the one you want to share the screen from?
Right, correct, yeah. And the number, the 07 number, the number ending in 07, that's my phone.
Has joined the meeting.
Yeah, yes. So you should be able, there should be a share screen, share your screen button at the bottom.
Okay, perfect. Yes, I see it.
Great.
So first I'm going to just share some talking points about COVID-19 and where we currently are when it comes to the cases as well as vaccination rates. And then after, I'll share my screen to share you the neighborhood profile of exactly what's going on in specific neighborhoods that your community board covers. So firstly, all information that I'm given is as of February 24, 2022. As you know, information changes, and as the information changes, I'll be sure to let you guys know. But as you can tell, everything is like changing, right? With the mask mandate and everything, and vaccination mandate, et cetera, et cetera. So today, the vaccination data in regards to vaccines, we are at 16.8 million, a little over 16.8 million vaccines have been administered to people, which is really, really good. And 6.3 people have been fully vaccinated. So we're making huge strides when it comes to vaccination. People are getting vaccinated. We're still encouraging people that are unvaccinated to please get vaccinated as well as get your boosters if you can. So the Omicron wave, right? It has passed, but what should I be doing now? Firstly, again, as I said, get vaxxed, stay up to date with COVID-19 vaccines, get vaccinated, get boosted. Mask up, Continue to wear your mask whether you're vaccinated or unvaccinated in public indoor settings where vaccine status is not known. Get tested. If you've been in contact with anyone that you feel might have COVID, get tested. If you're feeling sick, please stay home. And as always, wash your hands no matter what. Also, the booster incentive. If you're unaware, if you get vaccinated or get your booster shots at a city vaccine site, we're offering a $100 COVID-19 vaccine incentive for New Yorkers who decide to get vaccinated at one of our sites. And that will be going on until February 28th. For more information, you can go to nyc.gov/vaccine incentives, and I'll post that link here in the chat so that everybody has it. To date with the mask mandates, so as you know, the state vax or max mandate for businesses has expired, right? Based on the governor's stating, but everyone over the age of 2 who can medically tolerate a mask, regardless of vaccination status, should continue to wear one in public indoor settings. So in New York City, we're still recommending that people wear their mask, especially when you do not know people's vaccination status, just to protect yourself as well as individuals who may not be vaccinated. Unvaccinated individuals should wear a mask in all public settings, indoors and outdoors. Mask mandates remain in place for schools, child care, public transportation, health care, and congregate settings. As well, the key to NYC mandate, which means if you're 5 or older, again, get vaccinated. You need to be vaccinated in order to participate in certain indoor activities, as well as dining in certain businesses in New York City. So COVID-19 treatment options. So first, it's important to note that treatment is not a substitute for vaccination, right? Again, as I've mentioned multiple times, get vaccinated and get boosted. But there are 2 types of treatments available to New Yorkers right now. There's the antiviral pills. There are 2 antiviral pills currently authorized and available. These are for people aged 19 and aged 12, my apologies, and older, who test positive for COVID-19, have mild or moderate symptoms for 5 days or less, and are at high risk for severe illnesses as defined by the CDC. So you have to fall into those categories, right? Again, we want to provide medication for those individuals that are experiencing severe symptoms of COVID-19. So it's not like, okay, you test positive, you automatically qualify. We want to give this treatment option to individuals who are severely suffering from the virus and get them as much aid as possible so that they can make strides to heal, right? And then lastly, we have the monoclonal antibody treatment. This treatment is a one-time IV treatment for people aged 12 and older who test positive for COVID-19 and have mild or moderate symptoms for 10 days or less. And again, based on CDC requirements, are at high risk for severe illness. Again, we want to emphasize that treatment works best the sooner you begin. So it is important to get tested right away if you have symptoms or were recently exposed to COVID-19. If you test positive for COVID-19, talk to your provider about treatment options. If you don't have a provider, you can talk to an H+H provider by going to expresscare.nyc or call 212-COVID-19. And again, I'm going to post this information here in the chat box for reference. Next up is isolation and quarantine guidance. So New York State issued update isolation and quarantine guidance. You no longer need to get an isolation or quarantine letter from the New York City Health Department. If you need an order for paid sick leave, you can fill out the forms and share them with your employer or school. And again, I will post the links in the chat so that you can see how those forms look in case anyone needs to access those forms for work. The hyperlink doesn't work. So, Nina, I'm going to email it to you so that you can share it after the meeting, okay?
Yes.
Okay. So I know if anyone has been kind of like listening to the media, the mayor has been speaking about getting rid of the vaccine mandate. So we want people to know that as of now, that is still in order. I mean, it's still in place. The vaccine mandate is still in order. Keep the NYC is still in place. In effect now, the city workforce, you still have to be vaccinated if you're a city employee. Certain high-risk extracurricular activities for anyone 5 years or older, you have to be vaccinated. Healthcare workers, childcare workers, non-public school staff, again, and that's it. Sorry, my apologies. I'm just reading. But so for right now, those are the updates that we have from our office. What I'd like to do now is share information about current data going on in the 4 zip codes for your community board so that you can kind of get a view of exactly how the numbers are looking in your area. Okay. So all you would have to do is do nyc.gov/health. So this is the main page of the city website, and you can click on COVID. So when you get to COVID, there's a lot of information here, right? And more specifically, when you go to the left side, you can click on data. And the first thing that I want to point out to everyone is why it is very important to continue to educate the community on why it's important to get vaccinated. So when you look on this section right here where it says cases, hospitalizations, and deaths, you can see how the cases for unvaccinated individuals are way higher as compared to people who are vaccinated. And again, that's why we're continuously encouraging individuals to please, please, please get vaccinated, because the rates are significantly less when it comes to individuals who are testing positive for COVID-19 compared to those that are vaccinated compared to those who are unvaccinated. So I just wanted to point that out. And then to speak on the variants that are currently right now that we're tracking, as you know, Omicron is the one that individuals are consistently testing positive for when they get tested for COVID-19. So these are all the strains right here that you're able to see. And as of now, again, Omicron is the one that individuals are consistently testing positive for. And then you can go to data by zip code. So this is where you kind of get like a neighborhood data profile of specific neighborhoods. So I'm gonna start with, so I know that there's 4 zip codes within this community board. I can do all 4 if you want, but I'll show you how to get the information starting with 11210, which is actually the zip code that I live within. And those neighborhoods are Flatlands and Midwood. So just some things that I want to point out. So where the city wants to get, so what's considered like a good transmission, well, a consistent, a low transmission rate is, ideally we want our cases to be 56 cases for moderate transmission, right? So we kind of want anything below 56 per 100,000 people, we want the numbers to kind of meet that perimeter, because what it shows is that in that neighborhood, the cases are they're stable and they're low, they're coming down, and in essence, COVID-19, the virus is being controlled well in that community. So specifically for 11212, we're at moderate transmission. There's 46 new cases per 100,000 people, which is great. This is great. And then when we go down, you can look at the population size, the cases to date, the death rates to date, and people vaccinated at least one dose. And then when you come down here, you can actually compare Brooklyn's case rate compared to the zip code. So specifically here for vaccination, right? We'll see that Brooklyn's vaccination rate is 78.1. And specifically in 11210, the vaccination rate, meaning at least one individual has received the COVID, has at least individuals in this community have received at least one dose, is 65.96%, right? So that's showing that the vaccination rate specifically in this zip code is lower in New York City compared to New York City's vaccination rate, which is 85%, and Brooklyn's vaccination rate, which is 78.11%. So I'll just quickly put in the other neighborhoods so you can kind of see what the numbers are. Again, substantial transmission. So the numbers here, the case rate for COVID-19 here is a little bit higher. So again, you can focus outreach here, right? Encouraging individuals to please get vaccinated and continue to wear your mask. And then when you go down here, again, you see the case rates, the death rates, and the vaccination. Here, again, the vaccination rate compared to Brooklyn as a whole and New York City as a whole is a bit lower. So again, this is where you can focus your outreach on getting people to get vaccinated and maxing up. And then the last two, 11226. So this is at moderate transmission. Again, right, we want to see this number at 56. It's 46, so that's great. That means that the cases per 100,000 people are going down. And then when you come down here, the vaccination rate is a bit higher, right? So that's great. It's above Brooklyn's 78.1 rate, but still lower than New York City's rate, but not far behind. So that's great. It's showing that the vaccination rates are slowly going up. And these numbers tend to change daily. And then the last zip code is 11230, Midwood. So we're at substantial transmission here, 53.63. So it's slowly coming down, which is a good thing. Again, it's below 56, so that's great, right? We want to see substantial and moderate. Those are the numbers that we want to, the words that we want to see here when we go to this community profile. And then again, you scroll down, vaccination rate, again, lower than Brooklyn's vaccination rate and New York City's vaccination rate, which is 85.82. So again, I'm just going to post this link here for people who want to have easy access to it, to give reference to go back and continue to see how their neighborhood is doing. Okay, so that's pretty much the information that I have right now in regards to COVID-19 and the current data here in New York City. If anyone has some questions, feel free to speak out loud or just post in the chat, and I can address them.
It's looking question free. It was a very thorough and informative report and gives us resources to answer some of our own questions, Afia. Thank you.
Yes.
Yes,
No problem. What are the ways to improve vaccination rate that are lower? So I would definitely say ways to improve vaccination is just continued education and holding spaces like this, letting people see the numbers and showing them specifically, right? Like, so initially the first page I had shown was what the vaccination rate was between people who are vaccinated, what the COVID-19 case rate were between people who were vaccinated and unvaccinated. And the reason why I did that is because it shows you, right? It shows you that people who are unvaccinated are more likely, right, to test positive for COVID-19 versus people who are vaccinated. So those are ways that you can continue to have conversations with people to really encourage them to get vaccinated, to stay up to date with their vaccination series and as well as getting their booster shots if they haven't.
Thank you very, very much for that presentation. As Sean said, that was very thorough. Nina, do you want to announce the next speaker?
So, I'm sorry,
What?
Joelle, there was one more question. It
Oh,
says,
okay.
Mayor Adams renews the current city vaccination mandates every number of days. So when did he last renew them and when do they expire? So yes, the mayor's office is consistently it's going to be as we were told today, it's going to be a very busy March. Every day the information changes, right? But as of now, everything that I had reported on is the way that it is as of today. And as I mentioned, tomorrow, everything can completely change. So things are, kind of change. Things are continuously changing with the new administration. As of now, besides the governor, kind of softening the mask mandate, that's the only thing that has changed right now. Now, what's in talks right now is about the vaccination mandate, where it's going to be recommended and where it's going to be required and where it's not. Again, the mayor's office is still in talks about it, so there's nothing is going to expire anytime soon. But as I said, anything can change.
Thank you.
So
very
the next
much.
question,
I'm
no
sorry.
problem. The next question is, do you have any advice for people who are anti-vax? I'm vaccinated, but I don't know what to say when people say things like their trackers. Okay, so again, we do understand that there are people who might choose not to get vaccinated because of religious reasons, or whatever be the case. But from a health department standpoint, and even as a family member or a friend, all you can do is provide the data and the information so people can make their own informed decision, right? We want people to feel comfortable making this decision. We don't want people to feel as if they're being forced to do anything, right? But again, provide information and allow people to make the best decisions they have to for themselves and their health and their family.
Co-chairs, I think that allows us to move on to the next section of the agenda.
Thank you. Nina, you want to introduce our next the doctor?
I am just
And
about that.
many thanks, Afia.
Thank you. Yes, very much. Thank you, Sophia.
It's
Hopefully,
excellent.
No problem. Thank you.
Hopefully meet in person sometime.
Yes.
So our next speaker is a name that I often see on my HHC email, and that is Dr. Michael Augenbraun. Am I saying it correctly, I hope?
That's pretty good.
Would you like to correct my bumbling through it?
That's fine. I've heard every permutation of my name you can imagine, so
I'm
it
not gonna,
makes little difference. That sounded quite good, though.
I'm not going to ask you to try mine because that's another challenge.
Sure.
Anyway, so Dr. Augenbraun is an infectious disease specialist with NYC HHC, Health and Hospitals Corporation. And he's an attending with SUNY Downstate and Kings County Hospital. So with that, I'm going to let you take it away. And thank you very much for being here.
Sure, my pleasure. Thank you. Thank you for inviting me. I guess the previous speaker touched on a bunch of subjects that I might have talked about. I may mention a little bit about some of those topics, but try not to dig into the weeds too much since it's getting late in the day. Just by way of introduction, as was stated, I'm actually the division chief in infectious diseases at both Kings County and Downstate Medical Center. I've worked at both institutions for over 30 years. I started my career during the last epidemic, and I feel like here I am somewhat wizened and certainly grayer in a new epidemic and pandemic. So I don't know if there's some symmetry to that, I suppose. Anyway, you got an earful about some epidemiology about where the disease is in the community right now. I can't add too much to that. I will say that Right now, we're in a very sweet spot from the hospital standpoint, both hospitals that I work in. We were, needless to say, in the spring of 2020, completely overwhelmed with a tsunami of patients. We were almost incapable of taking care of so many sick patients. Right now, at both hospitals I work at, the number of hospitalized patients with documented COVID is under 10 at both hospitals, and that's a dramatic improvement, and as you heard, the numbers in the community are coming down and quite low. The state numbers suggest that in Kings County, the positivity rate has been hovering around 1% for at least about a week and a half, I would say right now, which is quite remarkable considering where we were just a few weeks ago, starting right around the Christmas season and working its way through January with the spike in Omicron cases. I'd say the rates now are probably as low as they were earlier in the fall when numbers were going down so low, we were all beginning to let our guard down. So that's an encouraging development. I think people are a little bit shell-shocked though, and so they're unwilling, many people are unwilling to sort of give up the security of some of the things like masks, so on and so forth, while other people are just so fatigued, I think, that they want to just go back to normalcy. And it's a little bit of a stressor for all of us. I don't have an answer about where things are going to go. I'd like to be cautiously optimistic and think that the last wave, the Omicron wave, will be the last of the waves. For those of you as old as me who can remember the Spanish flu in 1918, there were 3 waves there too, and then the disease went away inexplicably. So maybe we'll do something similar now, but this has been very unpredictable. So you'd be foolish to bet the farm on that. So, at the moment, after the Omicron wave, we really haven't seen any subsequent, we really don't know anything about any subsequent waves of new variants out there. There is sort of a B2 strain of Omicron that people are watching. I think to a certain extent, we're sort of victims of the benefits of science and that we can study these variants so closely and monitor them as they pop up. They're a natural consequence of unrestricted reproduction of microbes. You see that with bacteria too. If these things reproduce enough, they pop out mutations, and sometimes the mutations provide for better survival of the microbe, and sometimes they actually inhibit the growth of the microbe. But that's nature's way. So this is not all that surprising. Coronaviruses are part of nature. Most species suffer with their own versions of coronaviruses. We as humans have been suffering with coronaviruses from time immemorial. There have been seasonal coronaviruses that have been causing basically colds forever and ever and ever. Before COVID, if you got a cold during the winter season, there was a good chance it was a coronavirus, but we were adapted to that virus and had sufficient immunity so that it didn't cause any kind of trouble. As I said, other animal species have their own coronaviruses that are similar but not the same as our coronaviruses. And one thing that we've learned, and this is certainly true about influenza as well, is when organisms jump the species barrier, they can wreak havoc. And that's true about flu, avian flu, as you've probably heard of, the mixing of flu strains in pigs worldwide can also result in the development of strains that suddenly we are no longer capable of resisting. And coronavirus has been acting somewhat similarly in that regard. I think everybody's sort of familiar with the story about the current strain jumping the species barrier somewhere in China, which is probably what arose, maybe bats, maybe other intermediate hosts. The SARS outbreaks that occurred in the early 2000s were probably very similar, jumps of different types of coronaviruses from animal species. And it's largely a consequence of our living close in some places on the globe, living closely with animals, infringing on natural habitats of animals, and our ability to move around the globe so quickly that permits these strains to spread as rapidly as they do. It's not helped at all by the fact that these coronaviruses are highly transmissible. That's one thing that we've learned about them. Some bacteria and viruses that affect human beings are not that transmissible. They have to work really hard at going from one individual to another. But the coronaviruses seem well suited for rapid spread. And interestingly, the Omicron strain that popped up in December was the king of spreaders. Its capacity to spread from individual to individual rivals probably some of the most infectious agents that we've been dealing with for very many years. Just as an example, people are familiar with varicella zoster virus, the cause of chickenpox and shingles. The infectivity rates for varicella in individuals who are not immune is hugely outstrips other infectious agents. The same can be said for measles. Highly infectious agents for people that are not immune. And the SARS-CoV-2 reaches that level and may even actually exceed in terms of the Omicron strain. So that's one of the reasons why I think we were all sort of shell-shocked in December when this thing spread as rapidly as it did, and caused a lot of breakthrough infections in people who had been vaccinated. You know, thankfully, it didn't seem to cause the same level of severe illness that other strains of the virus had caused early on in the pandemic. And the reasons for that are not entirely clear. I'm thankful for the fact, but it's not entirely clear. Some of it, I'm sure, is attributable to the highly vaccinated proportions of the population that limited the amount of disease. But there may be some other viral explanations for why it was not as deadly as other strains have been. There's some science suggests that this virus seems much more adapted to reproducing in the upper respiratory tract and less able to colonize and infect the lungs, which is where the damage of the disease actually occurs. It also might explain why it's so readily transmissible, because if it's localized in the upper respiratory tract, it's easier for us to spread it to one another versus spread in the lungs. So those are some of the theories about the spread of the virus. I will say, though, that having said that, about the spread and the less lethality of Omicron, you have to recognize that there are still people in hospitals who are quite sick from Omicron. And there are people that are dying from Omicron. I don't want to minimize this. And I will say, to sort of piggyback on something that the previous speaker said, I think alluded to, in my experience over the last couple of months, generally, almost uniformly, the people who are sick and hospitalized and those who die now are unvaccinated individuals. And it's worth recognizing that to make a pitch for vaccine in individuals who have not accepted this intervention. There may be other individuals, in particular immunocompromised individuals, who can't reap the benefit of the vaccine because their immune system is so weak, who are vaccinated and yet who get very sick all the same. And I'll say something about things that we can do for those folks in a few minutes. But almost uniformly, the people who are the sickest in the hospital these days and dying are people who are unvaccinated. And I you know, it's just that experience alone makes me want to make sure everybody gets vaccinated. So we talked a little bit about the microbiology of the organism. We talked a little bit about epidemiology, the natural history of infection. Well, like I said before, upper respiratory tract, lower respiratory tract. It seems capable of causing lots of different problems, actually, pathophysiologically. We have people who present to the hospital with gastrointestinal upset, diarrhea, who turn out to have COVID. We have people who complain of fogginess in their thinking and altered mental status, and that turns out to be COVID. We've seen people show up who've had what we refer to as thromboses, acute thromboses. And this was actually much more common at the very beginning of the pandemic, when people were showing up with heart attacks and strokes, who it turned out were victims of COVID, and this was their manifestation of disease. We see that less commonly now for reasons that, again, remain somewhat unexplained. But it was a dramatic presentation. People with deep venous thrombosis, pulmonary emboli, so on and so forth. You know, fascinating stuff if you're interested in pathology, but deadly stuff and tragic and scary stuff for most people. So that's sort of something about a quick word about pathology. As far as infection is concerned and transmissibility, people generally speaking are likely after exposure to become infected within about 5 to 7 days, anytime within 5 to 7 days after exposure. And in general, we've been screening people who've been exposed about a week after exposure to determine whether they're going to go on to develop illness or not. If you don't turn out to have positive testing for COVID after about 7 days following an exposure, it's highly unlikely that you're going to develop infection. Some people have asymptomatic infection too. Don't get me wrong. Some people will get infected and not have symptoms at all, or have minor symptoms and spread infection. And again, it's one of the odd things about this infection is that the response can be quite variable. Some people are very sick. Some people are not so sick. We have many methods for testing and diagnosing COVID, most of which I'm sure you have some familiarity with. The main method of testing for COVID right now are what we call nucleic acid amplification tests, or molecular tests. And these tests are somewhat new, I'd say, in the last couple of decades, sort of a new paradigm for testing for microbes. I mean, everybody's sort of familiar with plating microbes on gelatin type material, agar in a plate or something like that, but that's very old school, Louis Pasteur stuff. The nucleic acid amplification tests allow us to actually probe for minute quantities of genetic material that are the signatures of pathogens. And we can do that rapidly, and we can do that on a single specimen to multiple pathogens. So when you go to get a test and somebody sticks a swab in your nose, the likely test that you're getting, the best test that you could get, is one of these molecular tests. They're the most sensitive and the most specific tests. They'll find it, and they won't identify erroneously other infections. Now, there are other tests out there that will sample the same sort of specimen, the nasopharynx, that simply look to identify protein material from the virus. And though a lot of rapid tests that are currently available right now depend on that technology, and they're not bad tests. If they're positive, that's usually conclusive evidence that they're positive. The problem is that they're somewhat insensitive or less sensitive than the molecular tests. So a negative test on those antigen tests may not mean that you don't have that infection. So you have to be a little bit careful about over-interpreting those tests. The molecular tests are by far and away the better tests of the two, more expensive, obviously, more equipment necessary to do the testing. The other tests that people are probably familiar with are serologic or blood tests. And the blood tests are never to determine whether you actually have the infection. All the blood tests can tell us is that you've developed antibody to the pathogen. And that means that you may have had the infection at some point in time, but we can't tell when. And one of the further confusing things about the blood tests is that there are blood tests that will check for infection and that will not pick up antibodies developed as a consequence of the vaccine. And then there are blood tests that will do both. And you have to be a little bit careful again about over-interpreting that. I remember when they first introduced the vaccine, a lot of people, after they were vaccinated, went out and got blood tested for antibody, which came back negative. And they freaked out because they said, I didn't develop antibodies, the vaccine didn't work for me. When in fact, what was happening was that they were testing with an antibody test that didn't pick up the types of antibodies developed as a consequence of the vaccine, so that they were overreacting to that development. So you have to be a little bit careful about what kind of antibody test you may be getting. But again, in the setting of an acute infection, antibody testing is really not that helpful. You want that molecular test or secondarily that antigen test. Talking a little bit about prevention, which was alluded to quite a lot in the last discussion, there are several ways, obviously, we protect ourselves. I'm glad to hear that my colleague from the Department of Health talk about hand washing. It seems kind of a stupid, low-tech intervention that your mother told you to do 150,000 times over, but it remains the most important means of control of all sorts of infections in and out of the hospital. So I can't emphasize enough good hand hygiene. But mask wearing is important. And I know we've gotten into lots of battles about how much mask wearing, what masks to wear. You know, any mask is a good mask, to be quite honest with you, to a certain extent. But there are, there's sort of a continuum of protection, so that the N95 that everybody's familiar with is probably the highest level of protection that you can avail yourself of if you can get a hold of N95s. Or alternately, KN95s are probably almost equivalently good. These are very high filtering respirators. So they are quite protective. You have to, you know, we've used those sorts of respirators in the hospital for many years to protect against tuberculosis. And we used to have fairly rigorous programs for performing what we call fit testing to make sure that the N95 fit on your face snugly. It created a seal, nothing got through. Of course, if everybody's wearing an N95 now, we're not doing fit testing for everybody. So we can't be certain that the fit and the seal are absolutely spot on. But those still are the best masks to wear. I will also say that I don't know how long anybody can wear an N95 because it does restrict your breathing to a certain extent. And if you do have respiratory problems, and even if you don't have respiratory problems, to wear one continuously for an extended period of time is rather difficult. There are alternatives. You can double mask, wearing a cloth mask over a surgical mask, and that provides not the same as N95 protection, but quite good protection, maybe on the order of 60 to 70%. And then there are surgical masks which provide some measure of protection, maybe 30 to 40% protection. So it's not no protection, but it's not as good as an N95. But wearing masks in settings where you could be exposed would be important, both to protect you and to prevent you from spreading infection to other individuals. I'm not a politician, thank God, and I'm not really heavily invested in the argument about mask mandates. I have too many other things to do. So I can't really comment on where we're going with mask mandates. At the hospital, we all wear masks wherever we go in the hospital right now. It's become the uniform. And if I leave work and I go home and I'm on the subway, I wear my mask. Obviously, if I go to a restaurant, rarely these days, I take my mask off. It's kind of hard to eat with a mask on. But, you know, generally speaking, I guess I'm a little bit shell-shocked and I prefer to wear a mask in crowded situations right now. I'm not prepared to give it up. But I know other people are and are tired, and I understand that feeling. So masking is important. Social distancing has been sort of a part of our repertoire of devices. We do recognize that the COVID is spread through droplets, and we've had measures in the hospital for protecting against the spread of droplet spread organisms for many years before COVID. And that meant sort of isolating individuals within a perimeter of around 6 feet, usually in a bed in a hospital. And that's where we applied to COVID because we felt that most of the spread was via droplet spread. And so social distancing is somewhat important. There is some confusion and mix up with something called airborne isolation, which we apply usually to things like tuberculosis and measles, for example. And their organisms are spread by very fine particulate respiratory droplets that can linger in the air for a long time. We think these are generated usually during medical procedures, suctioning, bronchoscopies, endoscopies, so on and so forth. So we implement airborne precautions when those procedures are being done on people who are feared to have COVID or known to have COVID. But for most exposures, I think 6 feet is a general rule of thumb. And we've been exercising that. And I think that that's a useful measure, a useful thing to engage in. Although, again, I think as numbers go down and people are sort of hungering for a little bit of human contact again, it's going to be hard to get people to continue to do social distancing for the rest of their lives. I'm not sure it's really necessary. Which leads me to vaccination. Again, my colleague who came before me talked a little bit about vaccination. You probably have all heard enough about vaccination. We currently really have in the United States 2 active types of vaccine that we are regularly giving to people, the mRNA vaccines, the Pfizer and the Moderna product. The J&J vaccine's not really given much anymore. That was a different technology. Both mRNA vaccines and the J&J are essentially now been boosted, recommendations for boosting with an mRNA vaccine. And the reason for that is that we've seen that that antibody levels, which we think are the protective thing that the vaccines induce, decline over time, sadly, and don't remain high, and that it was necessary to get a booster to get those antibody levels back up, especially with the onset of the Omicron wave that we just went through. So the booster was recommended. And again, there's questions about how many people need boosters. Are the boosters really absolutely necessary? It's certainly recommended for people who are elderly, at high risk for complications, people who work in high risk environments like healthcare environments. But generally speaking, it's been recommended for most people because of the rapidity of the spread of the Omicron strain. Whether we're going to need additional boosters, I don't know. I don't know what the public health authorities are going to recommend. It sort of depends on how things go from here. It's also important to recognize that part of the problem is we don't really understand immunity to this virus all that well. There are several ways our bodies develop immunity to these things, and it's not just about antibodies developed as a consequence of the vaccine. There are other arms of the immune system. You may have heard reference to like T cells, memory B cells. These are different arms of the immune system that will respond to the vaccine, that will retain memory, but that are very difficult to measure. You can't just do a blood test like we can for antibodies. And so those are sort of wild cards in the immunity.
Corresponding secretary. And my scholarship really focuses on the use of simulation to enhance culture.
Please mute yourself. Thank you.
So the vaccines are, and I mentioned before the data about hospitalization and death in the unvaccinated. So the vaccines are really critically important as a tool for fighting this infection. And I'd have to say that after over a year since the introduction of the vaccines, I think we've had a generous amount of time to assess whether there are significant side effects associated with the vaccine. And certainly there's no such thing as an absolutely free lunch, and people do develop minor symptoms associated with the vaccine. And there have been rare cases of reports of people developing more significant allergic reactions, so on and so forth. But those are rare instances given the sheer numbers of people who have been vaccinated. And I'd have to say that these vaccines are safe and that they work tremendously well. And that's the message that most people have to get. How do you deal with vaccine hesitancy in the community? Again, I don't have a magic bullet for that sort of thing. I feel like I've been able to convince lots of patients who are on the fence about this within the bunch of months after the introduction of the vaccine. At this juncture, I think people who remain hesitant about receiving the vaccine are tougher and tougher to reach for vaccination, but it's still worth trying. Why do people feel this way about the vaccines? I think it's a multifactorial thing. I think it's a lack of trust in authority, the politicians, public health authorities. Everybody's come under scrutiny and criticism. There are, in some ways, no authorities left anymore that are not, beyond criticism and sometimes overwrought criticism. And then people have a hesitancy about taking shots into their bodies. They don't know how it's working, what it's doing to them. I think to a certain extent, immunizations are a victim of their success. If you think about the diseases that immunizations have basically eliminated from human society, the victories that they've wrought are extraordinary, much greater than almost any other medical intervention I can think of. The diseases that our forefathers had to and foremothers had to deal with that caused, for example, lots of childhood death, for example. We never see them anymore. Nobody has any experience with these things. And so people don't recognize the fact that the immunizations are what rid us of these things. Smallpox, nobody sees these things anymore because these vaccines have basically, at a very low cost, exceedingly low cost, rid our societies of these horrible diseases. So again, I think people don't see the benefit, they see risk, associated with these interventions. So I guess that's sort of what I wanted to say about immunizations. And I guess I'll wrap up just by talking about a little bit about medical therapies that are available right now. Again, my colleague mentioned some of these, but you should be aware that there are basically 2 medications available and monoclonal antibodies available for the treatment of individuals. I'm sorry, I should say 3 medications and 2 monoclonal antibody preparations available for the treatment of patients with mild disease. I didn't get into this too deeply, but COVID is sort of a biphasic illness. There's a viral phase early on where people get a viral infection, and then there's an unrestricted immune dysfunctional response where people get super, super sick. Sadly, in the second of those 2 phases, we don't really have a lot of good active therapies, but we seem to have reasonably good therapies for very early stage disease. And if we can identify those among us who are at the highest risk of going on to develop complications, the elderly, the immunocompromised, people who have not been vaccinated could be included in that too. And if we can identify them quickly as having COVID, we can give them these measures and we can actually protect them quite significantly. Monoclonal antibodies are one of the strategies. They're laboratory produced antibodies that attack the proteins on the virus and can be infused rapidly and only once, not necessary to get it repeatedly, and reduces significantly, if given early enough, progression of disease. There are 2 products out there, bebtelovimab, you can't say that 5 times fast, and sotrovimab. There are some questions I understand about the activity of sotrovimab against the newer of the Omicron strains, but that remains to be seen. But that's available, and our hospitals have that. Kings County has that, Downstate has that. Many of the hospitals have procedures for administering these infusions, and they're safe. They're immune globulin infusions. We've been using immune globulins for years for many different conditions, and they can be administered quite safely without any adverse consequences and given once. There are 3 medications that can be used right now. One of them is Paxlovid, another one is called molnupiravir, and the other one is called remdesivir. Remdesivir was introduced quite early in the pandemic for the treatment of severely ill patients, but it turns out, according to recent data, that remdesivir as well can act as an antiviral, and if administered early on, can abort the progression of the disease. And the same can be said for Paxlovid and molnupiravir. Molnupiravir, of the 3 drugs, doesn't seem to work quite as well. Paxlovid works very well, but because of its chemical nature, has a lot of drug-drug interactions, and you have to be careful about other medications that patients may be on before you administer it. But those sorts of things are well handled by most physicians. The last product I just want to mention is another type of a monoclonal called Evusheld, which is a monoclonal antibody that's specifically approved right now under an emergency use authorization as a pre-exposure prophylactic agent to be given to individuals who are immunocompromised who we think won't respond to vaccine quite well. And those include people like transplant patients who are on immunosuppressives so that they will continue to accept the graft or the transplant that they've received. Unfortunately, these immunosuppressives blunt the immune response to the vaccine, and they can't develop antibodies and the other means of fighting off infection. And for those individuals who are at high risk, this product Evusheld can be administered once every 6 months and basically provides them with ongoing immunity, essentially as if they had been immunized against COVID-19. And those are our therapies right now. So, in conclusion, we are in a much better place than we were 2 years ago with this. And I hope that this will progressively abate and go away and become something of a distant memory. But it's anybody's guess. It's probably bad form to try to outguess Mother Nature. So we'll just have to see. But I think we're in a much better place. And with that, I guess I will finish. It's getting late. And I will be happy to entertain any questions anybody might have.
Any questions, please?
I actually have, this may be a little bit of an offbeat question, but as a medical provider myself, I'm very curious. The mRNA, I know that people think, oh, they threw it together overnight, but those of us who have been following this know that actually the work began, I think, as much as 60 years ago. And certainly the recipes were essentially put together with the SARS and MERS viruses. But here's where I'm kind of spinning out just a bit, and that's that we know that the way the flu vaccine is currently made is really, really old school in terms of medicine. And I'm just wondering if you have seen or heard or project changing the way flu vaccination is made so that it's more like an mRNA, and which would also, by the way, I think, open the door to many people who can't get flu shots being able to then get vaccinated as well.
Yeah, I mean, the flu that's a good question, a good observation. The flu vaccine is really pardon my expression, it's a crappy vaccine. It's, the technology hasn't changed for many, many decades. And if you follow this stuff, the efficacy is not that good. Thankfully, the capacity of flu to spread is not as bad as, say, Omicron is, but the vaccine's poor. So we really could use a better mousetrap at this point. And I think one of the things that we will see as a benefit coming out of this is that we will be using the mRNA platform to develop vaccines for a wide range of things that will supplant currently available vaccines. And I agree with you. This didn't come out of nowhere. This is decades of work on these this mRNA platform. And, for people who say, it happened too fast, I mean, we're reaping the benefit of biomedical revolutions that have been occurring over the last several decades. We should take advantage of these things. You wouldn't want to go out and buy a car that was built on a platform 60 years ago. Why would you want a vaccine that was built on a platform 60 years ago? Again, you wouldn't want it if it just came out of somebody's garage last week. But again, these things were developed over decades, not over a couple of months. So I sort of agree with you on that observation.
Thank you.
Just a quick time check, co-chairs, because we do have another presenter, and we've had two very thorough and informative presentations. I'm so glad we record these and put them on our YouTube channel so that we can refer people back to take a look, because they're very valuable.
Informative, yes.
You.
And I see no other hands raised. If you'd like to introduce the next, thank
Thank you,
Dr. Augenbraun and introduce the next.
Be safe, everybody.
Thank you.
Nina, you want to introduce Burke?
Yes. Casey Burke, who has been waiting very patiently and listening to all of this, comes to us with he is a licensed master social worker, and he's the, I believe, the program director for Breaking Ground. Am I correct about that? Okay, and I believe you're going to be talking to us about the outreach programs and whatever else we here in at CB14 should know about what's going on in our community regarding people who are unhomed. Thank you very much.
And I'm going to interrupt Casey before she even begins, just to sing her praises, because she's very involved with the board. She's very responsive every time we call her. She's always a step ahead of us, and participates in all our district service cabinet meetings, et cetera. And I'm just a huge fan of Casey. I think she's great.
Thank you for that. I do have some slides. I don't know if I am able to share. I am. I think I can. Let's see if it works. Yeah, there we go.
Yeah.
Can y'all see my slideshow?
Looks great.
Okay. So just like a brief overview of what we're trying to do with the homeless outreach programs. So Breaking Ground, we oversee the homeless outreach for Brooklyn and Queens, and also Midtown Manhattan. Our funding all comes from contracts through DHS. So Breaking Ground as a whole, it's a larger agency. We do the street outreach component. We also have a drop-in center in Queens. It's currently a very small drop-in center that only serves 16 people, but they're going to start construction any day now to expand it to be able to support 75. We also have 307 beds in 3 different buildings of transitional housing, which are called safe haven programs. And we actually have 2 more safe havens that have come online recently, one in Williamsburg and one in Manhattan in Union Square area. And then our other safe havens are one in East Flatbush, one in Manhattan on the Bowery, and one in CB14 on 11, what is it? East 12th Street and Avenue H. Sorry, for some reason my brain is not working. So yeah, you'll have one of our programs in your district. In addition, we also have permanent housing buildings, which provide supportive permanent housing to folks who have experienced homelessness and have mental health conditions, people with HIV, people who are low income, and we're going to start moving into doing affordable housing as well. We have buildings opening all the time. We have one that is supposed to open this summer in Dumbo, which will be fantastic. It's 491 units of housing, so it'll be really a really big deal. We can open it. In all of our programs, we provide medical care and substance abuse referrals. We also have our own street medicine team, which goes out into the field to connect with folks who are living on the street and in need of medical care. They've done a lot with COVID, a lot of testing, a lot of vaccinations, and just a lot of general education during COVID, but they also provide, hepatitis C and HIV testing and treatment for both. They do a lot of work around harm reduction with people who are using substances, and providing people with clean needles and collecting their dirty needles and making sure that they're using as safely as possible. We also provide mental health care. We have psychiatrists on our team who will go out into the field to meet with clients. We're also doing virtual visits now, like everyone else. And people can come into our offices and meet people face to face as well, to provide. Everyone gets like a baseline psychiatric evaluation, and then from there they're able to, if they do want to or need to receive treatment, they are able to do that. And we also have kind of the army of social workers at this point, all of whom are certified by the state of New York to do involuntary removals from the street. The person does happen to be, experiencing mental health conditions or medical conditions even, and they're a danger to themselves or others. Because of that, we can remove them to the hospital and get them evaluated that way. Thankfully, we don't have to do that very often, but it is something that we have in our toolbox. We also have the ability to help folks get benefits, public assistance, Social Security, pensions, just kind of across the board, anything monetary that folks might be entitled to, but they haven't accessed. We help people get food stamps, obviously, and Medicaid and other Medicare, kind of other insurance benefits they might have access to. And then also try to help people kind of build themselves back up. People, a lot of our folks, they haven't been homeless for long, or they have had intermittent periods of being housed and being homeless, and so we try to help folks get back on their feet and attain the stability that they had before, and help them to learn the skills needed to live well on their own, but also understanding that some people will always need some help, and we do provide that assistance as well. So our program, the outreach program specifically, we're kind of under, Brooklyn and Queens are under one contract. I oversee the Brooklyn portion of that. And we provide 24/7 outreach. We have teams on the street all the time, looking for folks that we don't know, and also checking in on folks that we do know. We can offer people kind of immediate services, connecting them to a shelter if they really want to go inside right away. And also if they want to go to like detox, or they need medical care or something like that, we can help them get to a hospital. And then we kind of, in a more long-term way, we work with people to, determine who
has left the meeting.
We work with people to determine, how long they've been on the street and what sort of services they might be eligible for. And we refer them to our own case management. And our case management are, pretty intensive. They work with people kind of at their own pace to help them attain the benefits they're eligible for. And, with all of them, with the goal of getting them into permanent housing, having their own apartment. So, we do work with people experiencing homelessness, kind of different lengths of time. Our edict is all about, working with folks who are chronically street homeless and living on the street. But as time has gone by and the face of homelessness has kind of shifted in New York City, and we have a lot more people who are more short-term homeless, especially since COVID. We have a lot of people who maybe were very unstably housed, or they were living in situations where they were sharing with a lot of other people that it became unsafe during COVID. So they've moved to the streets. And so we're able to now provide a few more services to folks who are not chronically street homeless. We can offer, referrals to drop-in or shelter. We can provide street medicine services, refer to psychiatric services. We'll help with benefits. We can also, in some cases, if a person presents as like very vulnerable, for whatever reason, be it medical, psychiatric, sometimes people are in a location that's not safe, various other reasons, we can move people into housing before they become chronic. And chronic street homelessness means they've been homeless at least 9 months out of the last 24. And then our more robust services are provided for folks who are considered chronically street homeless, meaning, like I said, 9 months out of the last 24 months been on the street. And in that we provide people with case management services. We can provide them with transitional housing, most of which nowadays is in these safe haven programs I described. We provide medical and psychiatric services, and again, benefits assistance. We have a very stellar entitlement specialist who's wonderful and knows everything and is able to connect people to things we didn't exist with. We receive referrals from a lot of different people. We receive them from 311. The 311 system is set up such that if someone puts on a complaint with regard to a homeless person in need of assistance, then it's dispatched directly to my teams, and my teams go out and find the person. We are contracted by the city to get to those calls within an hour. We usually do. Sometimes the traffic is bad, or it's like a day where we are short-staffed, or where there are a lot of calls. Like we see upticks, like as the weather turns, like every season, kind of as it gets warmer, we'll see an uptick, and like as it gets colder, we'll see an uptick. So there are times when we have somebody called, it takes a while to get to them, but for the most part, we're able to answer within an hour. And then we get from elected officials, community groups, police, other service providers, concerned citizens. We get them from hospitals. I underline hospital too, because this is originally a presentation for a hospital, so I apologize for that. But we do accept referrals from everyone, because our goal is to serve everyone in Brooklyn who is chronically street homeless. And so, I've been the director of the program since December of 2014, and I really have made it my mission to meet as many people as possible, and as many service providers, as many organizers, as many community members, to understand like what's going on in their areas and what we can do to connect with folks that really need our services, because we do have the resources, we just need the people to give them to. Skip that one. And then this is just like a basic fact sheet of where folks can go and how they can reach out to outreach. There are the phone numbers for the Brooklyn Queens team and the Manhattan team, and directions about 311. The 311 is accessible, as you probably know, through a phone call, but also through the app. The app is very, very efficient, and I recommend it to everyone. You can just scroll down and it'll say homeless assistance, and you click on that. You put in as much information as you have about the location of the person, the description of the person, and it'll be dispatched to my team. And in some cases, if you put in, it's like there's different categories. I can't remember offhand what they are. Let me see if I can look it up. That there's one that's like homeless encampment. That one goes directly to the police. For my teams, it is, sorry. It's either homeless assistance if you want it to go to my teams. The police go to homeless encampment, and I think also to panhandling. So just a hot tip. And then there's another list on this side of where people can go for shelter intake. There's one intake center for men. There's 2 intake centers for women who are on their own. There's one intake center in Manhattan for people who are considered adult families. It can be a couple without children, a parent and a child, even just 2 children who, are codependent upon each other. We've had people that are just, 2 friends that become very entangled and, work together to keep each other safe. So it's a pretty broad definition. And then families with children under 21 and also pregnant women, there's an intake center for those folks in the Bronx. And then there are drop-in centers. There's one called Main Chance in Manhattan. The Living Room is in the Bronx. Oliveri is in Manhattan, also on the west side. The Gathering Place in Brooklyn is in East New York on Atlantic Avenue. And then Project Hospitality in Staten Island also has a drop-in. And then we have our drop-in in Queens, which is much smaller, but providing a definite service for a neighborhood that has very, very few services. That is my contact information. I am always open to receiving a call or an email. As I said, email is the best way to communicate with me. I'm kind of everywhere. But if you have a concern about a person in your area, or even just a question about how you can connect some of the services, if you are working in a public health setting or a social service setting, we can help you figure out, kind of troubleshoot what's best for that person. Stop sharing. Okay, so that's the rub on my program. Do y'all have any questions?
I'd like to recognize our district manager, Sean Campbell.
Thank you. I'm also, before I go though, I see there's a question in the chat about Code Blue, and during a Code Blue, are homeless taken inside? Are they allowed to refuse care and remain on the street?
They are allowed to refuse care. We offer them every option, and things are in that with that particular facet of our work are a little in flux. We used to be able to offer people, hey, just get on the train. It'll be safer for you, warmer for you to go down there. But since the last week, they made a new program to get people off of the train. So we're still working on figuring out exactly, but people can go, there are warming buses at different points in the city. Folks can go into a shelter for the night, even if it's just a very cold day and they want to get in just for, a few hours to get off the street, they can do that. They can't, we do assess you for safety. Some people are really prepared to be outside. They have sleeping bags and coats, and this isn't their first winter, so they can do that. But other folks that we know are newer or do have a psychiatric illness that keeps them from making good decisions, we would help them move in.
And Casey, my comment was, or it's a question, but I just want to remind board members and community members of our landscape in Community District 14, where we rank 7th out of 59 community boards in the city in terms of severe overcrowding in households, and we rank about 14th in the city in terms of severely rent overburdened individuals. And adding to that stresses on homelessness. I know the street homeless population differs somewhat from the sheltered homeless population, but 3 years ago we had 0 shelters in the neighborhood, and now we have one on our border that opened in 2019, one that will open at 1 Kenilworth in March, one that will open in November at 21 Duray Place, and a new contract going just outside of our border in 17, which will give us 4 shelters within 1.2 linear miles of one another. So I'm just wondering, like, to what extent that impacts, having shelters in the area. Is there an interaction between the shelter population and the street homeless population? Is it a benefit because you've got close places? If you could just talk about how those worlds interact in terms of your job, I'd appreciate it.
Yeah. I mean, it can be helpful because sometimes folks from a neighborhood want to stay in a neighborhood. And so if you have shelter options in your neighborhood, we can work with DHS to move people, like not have them, because normally you have to go through intake and then they'll place you in a permanent shelter. And in those cases, if there's someone in a neighborhood and we know them well enough to know they won't go anywhere outside of their neighborhood, we can offer them a direct placement into a shelter in their district or their neighborhood, they're on their block, if there is one. That takes a little bit of doing with DHS, but they will do it in more extreme cases. And, it does sometimes, it kind of depends on the provider that's overseeing the shelter, like what the impact on the neighborhood is. Like some providers, like Breaking Ground specifically, we do a lot of work to try and be good neighbors and try and like keep people from, congregating on the street or, keep there from being as much as possible substance abuse outside the building and all this other stuff that does sometimes come with shelters. Other programs, other agencies aren't always as good at doing that, but they, every agency is supposed to provide security. They're supposed to provide, appropriate case management for folks and to have activities for people inside and be helping people, meet their goals, whatever those goals are. So it shouldn't negatively impact an area, but sometimes does. And, in those cases, when there is a shelter that opens, we, we'll do outreach and make sure that the people that we're seeing on the street, if we're seeing people on the street, are not, experiencing street homelessness, but are connected to a shelter in the neighborhood. And sorry, some motorcycle. And sometimes, we can encourage people to, go home and also, if they're experiencing some issue at the shelter, we can help connect them to people at DHS to help them navigate that issue. And we had a question in the chat about a homeless woman that passed away on the train. It's a very tricky thing. That lady, I think it's the lady who passed away on the D train. She had been homeless for about 3, maybe 4 years and had been evicted from her home. There are resources for everyone, but we have to find them. We have to know we have to find them and they have to accept it. And everybody has the right to refuse. It's kind of like we all in our lives, we might know that there's something we need to do to make our lives better, make our lives healthier, whatever that means, and we choose not to do it. And I think that is, it's also the case for folks experiencing homelessness or folks experiencing mental illness or anything else, that if they have the capacity to make that decision, they can make it, and it can be a bad decision that can negatively impact their lives, but there's very little that we can do to force them. I do think that the focus on the subway system that started recently will help connect with more people, because I think it's a very challenging job to provide outreach services to folks on the subway, because it's a moving target and they do their best. They connect with folks mostly at the end of line stations, but they can't be everywhere at once. And so I think they're going to do more to get more staff, more social service staff onto the trains and to actually try and cover everything a little bit more robustly. So I do hope that adds some cover for folks. Any other questions?
Yeah, this is Joel Siegel. Thank you for your presentation. I have uh, one question, two questions. The first is, as you may know, we've had a homeless problem at Newkirk Plaza, and we tried to address it a few years ago. And someone from the organization was at a meeting, and I was sort of, for lack of better, blown away at this person's information that about how many interactions you have to have with people before they actually accept some level of service. So I think the people at this meeting should know that, because it's sort of mind blowing. And the second thing is, um, you know, where's the weak link in the services that you offer that makes people kind of not want to partake? Is it simply the bottom line shelter, the housing that can be offered? Is that it? So those are my two questions.
Yeah, I mean, on your first point about, the amount of time it takes to connect with people, it's in the more extreme in some cases where, what we say is, like on average, it takes about 100 visits before someone is really open to meeting with us. And so it might not be as many in some cases. Some people are really ready when we meet them. They've been waiting for us to find them. And other folks are harder nuts to crack. And I personally have experienced, like I had a guy, he was on the street. I went to him every single day for 2 years before he was willing to go anywhere. And it just really takes us being there, being present, and creating a relationship with folks so they can trust us that we're actually going to help them, and we're not going to push them to do anything they're not comfortable with, and they'll be able to provide the services that they actually want and they actually need, versus kind of forcing on them our agenda. And I think the gaps in service are big. It's like an American problem. There's if we had a better healthcare infrastructure, a better mental health care infrastructure, that would solve a lot of people's issues. If we had paid sick leave or paid maternity leave, or like all of those things that are on my socialist agenda, they would really help. I think in New York City specifically, it is the cost of housing is so huge. There are a lack of options for folks that just want to rent a room. Like we have clients who are able to live on their own, but their income from working off the books or working a minimum wage position is not enough for them to pay rent. And so if they were able to rent a room for like $500 a month, that would be perfectly sufficient for them. And there just aren't those options out there. There used to be single room occupancy hotels kind of across the city, and they were good and bad in that a lot of drug activity and crime and stuff like that happened at them, but they also provided they met a need that we can't meet right now. So yeah, I think you have to address, a lot of different systemic issues to address homelessness. But I think the housing thing is kind of the first and most like tangible facet that we would need, because you can't get people off the street unless they have a place to live. Another question?
Thank you very much. That was very profound.
Yeah.
Florencia has a hand up.
Hello, good night. My family and we go out and we feed the homeless. However, I wanted to ask, I meet different people. Some admit they have mental issues, but a lot of them say that they're not safe. They don't feel safe in the shelters. And so I wanted to ask, and I've known folks that have been through the shelter as well that have said it's not safe. As a matter of fact, there's a nurse that she and her daughter, her kids, 2 kids, were in the shelter, and her daughter got slashed in the face, in a shelter when they were in the shelter as they transitioned through. So I wanted to ask, how safe are there policies being set in place that will make the shelters safer? And, about the programs, mental health programs. And then finally, I wanted to say that lately I've been seeing more homeless people within the bank, in the foyer of the, the ATM section of bank, of the TD bank, of the BOA bank, at the junction on Church Avenue and in Manhattan. So, and I mean, during the, like, I know some, like, I almost tripped over one gentleman. He laid across, and it was during the day. It wasn't like, it wasn't nighttime or, not peak hours. So what is being done for that?
So your first question about safety in the shelters, the shelters do have a reputation for not being safe. Part of it is that there's just they're oftentimes large places with lots and lots of people kind of crowded in there, and that can create just dystopia of people not getting along and things happening. And it's again an unmet need that you have people who they're released from jail or prison with nowhere to go, and in order to comply with their parole or probation, they have to be housed somewhere, and so they go into the shelters. And we do hope that people are rehabilitated, but sometimes they are not, and sometimes they are they're preying on other people, and so that does happen. There is active drug use in the shelters. Another issue is sometimes people with psychiatric illness are supposed to be able to go into a shelter that has services for them, but that's not always possible, or maybe a person won't agree to go to it, or they don't stay in shelter long enough to be assigned to a permanent shelter, and so they end up in the intake centers, and the intake centers can be kind of really overcrowded and kind of chaotic and create difficulties. You will say always that most people with mental illness are not dangerous. It's more often that they are victimized than they are victimizers. So we need to keep that in mind, and do our best to connect folks to services. But yeah, the shelter system is obviously very imperfect, and thankfully with the outreach programs we have some resources outside of that framework, and are able to provide people with something where they get their own room sometimes, or where at least there are fewer clients, so they have a little more breathing room, and also there are fewer clients and more staff, and so they're really actually getting the case management services they're supposed to help them move forward with whatever their goals might be. And all the shelters are supposed to have programming. They're supposed to have, case management. They're supposed to have groups. They're supposed to have different stuff, or at least connect people to stuff outside. But again, it's a very overtaxed system, and so that's not always possible. As far as folks in the ATMs, I think COVID took away some places where people used to hang out during the day, and even at night. During Code Blue, and every other year, aside from the pandemic, the ED waiting rooms have been open for folks to stay in all night. And it's been part of the city's Code Blue policy that people could stay in either the waiting room, or just like in like Kings County, they have the big waiting room in the front entrance. People could stay there and stay there until the morning when it was warmer and safer for them to be outside. But that went away with COVID, obviously, because the hospitals are so overcrowded, and it is a health risk, transmission risk. So that location, or like the library is not being open and stuff like that, have taken away a place for people to go and spend time when it's cold outside, especially. And so I think a lot more people have been taking up residences in things like ATM vestibules and other kind of spaces that are easy to access but not appropriate. And in those cases, you can call 311, and my teams will come out and talk to the person and try and connect them to services.
Thank you very much. Thanks.
Any other questions?
Sean, I have to leave the meeting, so you could wrap it up. I appreciate it. All right, thank you so much, Casey. It's very informative. It's sad but informative. Be well.
Yeah, I'm always grateful to CB14. Y'all are very supportive of our work, and we very much appreciate it.
Thank you so much.
Casey, I'm going to share. Are you still there? Oh, quickly. I worked as a like a substitute NP at it's kind of a transition shelter on Randall's Island, where people came in, some from drug rehab programs or detox programs, other kinds of things. And they started at the bottom. They had to clean the grounds, clean the toilets and so forth. And then they got, increasingly more responsibilities and job training and stuff. And as I was about to get on the bus from Harlem to Randall's Island, somebody actually pulled me aside and said, quick, you have to sign off on my PPD so that it's go back today. And I said, you gotta show me both arms, because I didn't, in case they were hiding, whatever.
Yeah.
And I said, you're great, boom, signed off their notes so they could go in for the day. But it was a very interesting experience, kind of a different situation from what we typically think of as homeless, because people, we had somebody who had been in construction and was like a millionaire, and he got into cocaine. Boom, his entire career, savings, everything right out of the water, and fortunately wound up in rehab, and there he had to inch his way up from literally the bottom. I mean, the people when they first came in had very, very menial, kind of the lowest of the low responsibilities, but still responsibilities to the facility. And then as they showed that they were responsible, they would gradually work their way up. And we had one man who came in, nice 3-piece suit and his attaché, and he said, I came back because I used to be here, and I want people to know you can make it. And it's fantastic.
Yeah, I think it's one of the first things we learn in homeless services that it can be anybody. We have people who are very educated or very successful, come from wealthy families. It doesn't matter. It can be anybody. And then I think that helps sometimes to do away with the stigma and the prejudice around homelessness.
Anne Goodette, you have something? You have a question?
Yeah, I do. Thank you so much, Nina. Casey, I wanted to commend you very much for the work that you do, and you do it with such compassion, both, and you've been able to make your program far more robust since the last time you were here. So again, I commend you, or I think we commend you. So I wanted to ask you two things. One was in the chat, but it wasn't brought forward. So, and that's earlier, prior to these last rounds of dreadful storms that caused people who were renting basement apartments who sadly lost their lives because of flooding conditions and egress difficulties. So is there an increase in discussion of the possibility of SROs returning? That's one question. And the second is, off the top of your head, would you have any idea of how many working poor are in the shelter system? Because there are quite a few, as well as children. So thank you again for all that you do for not just our area, but for the greater metro area. We really appreciate it.
Yeah. Thank you. So as far as SROs, I think it's a hard sell for folks to restart having SROs. I think basement apartments, some of them legal and some of them not, were kind of almost hidden from view before those terrible, terrible storms and the people that died. And I think it's a similar thing with SROs. There were a lot in Manhattan, especially, that were great. And I had clients that lived in them for years, and it was exactly what they wanted, exactly what they needed. And they were turned into condos or into expensive apartments. And so it's more, in that way, it's more about the money than anything, I think. There's also, I think a little bit of stigma around them. We all, I think, assume that people want, a 1-bedroom apartment or a 2-bedroom apartment. They want to live like we all probably live, in a place where we have our own bathroom and our own kitchen, and that should be everyone's goal. But for some people, it isn't. And I think that we need to accept that people live in different ways and are comfortable in different ways. I joke around about living in a tiny house. I would love to have a tiny house. But yeah, I think it would be really wonderful. But yeah, like, I think we have to open our minds, especially in cities like New York and in the Bay Area and California, where there's so little space to build. You have to open your mind to different ways to house people in different, settings that people are comfortable in, like kind of communal living situations and different things like that. SROs are one of my banners. I believe it would solve so many problems if we were able to have SROs again, or even just some of the YMCAs. The YMCAs used to, they had rooms people could rent for $500 a month or so, and they were safe and pretty comfortable. And now most of the YMCA beds, I'll say, are rented to shelters or to providers like myself. And so it's people who are experiencing homelessness and moving in there, and my agency is paying the rent for those people, versus just a dude off the street being able to walk in and rent a room. So I think that is definitely an unmet need. I've been talking for about 12 hours now. So yeah, I think it's, and I have, whenever I have meetings such as this or with other city officials, they'll ask me, like, what can we do? What is the thing that you need? And I'm like, SROs. So that's my better. That's my ask always. And you had another question. No, working poor. I don't really know. I don't think there are actually numbers. There are specific shelters for single people who work. But there's not really any numbers that I know of that specifically talk about how many people in the shelters work. I think it's a large number, especially in the family shelters. It's a very large number.
See, sorry to interrupt. I just remember Jelani Mashariki with his Black Vets for Social Justice, their shelter on Coney, when he was introducing that to the community, he said that 30% of the men that they shelter have jobs. So I don't know if that's representative or if Jelani cherry picks or what, but that is a pretty good
Yeah,
percentage.
I think it's entirely possible. Yeah, it's I think that like a lot of people have low wage jobs or situations in their lives where they don't have the ability to save money, and so that keeps them from moving into from being able to afford a home. They can't pay the deposit or the first month's rent or any of the other things that they're still required to do, and it keeps them from moving forward. So yeah.
Thanks again. And Nina, it is past the 8 o'clock hour, and Casey's been talking for 12 hours. So if you want to wrap it up and let her rest her voice.
I'd just like to say, thank you very, very much. And we appreciate all that you do. And it was a great presentation. And we hope that we will have you back in the future to say that you're out of a job.
I solved homelessness.
Okay, so we will adjourn the meeting. Are we good for that?
Yes, thank you, everybody.
Everyone who attended.
Good night.
Good night.
Thank you so much. Good night, all. See you next meeting.
Good night, all.
Has left.